Hey guys, Dr. Justin Marcagiani here. Welcome back to Beyond Wellness Radio. Really excited. I have Kat Simmons here today who works for GI Map Diagnostic Solution Lab. So really excited. We're going to talk about stool testing. We'll talk about microbiota imbalance, everything gut related. We're going to try to get to the root cause so you guys walk away with some great actionable information. Kat, welcome to the podcast. How you doing?
I'm good. I'm good. Happy Friday. Thank you for having me. Happy Cinco de
Yeah.
Mayo.
Yeah, oh yeah, I forgot. Absolutely. Haven't seen a mile. Very cool. Well, nice to meet you here over the video. This is great. So tell me a little bit more about you and your background. I know we chatted earlier, you're a dietitian by training, a lot of functional medicine training. How did you get into this field coming from conventional dietitian land, which is, a lot of times the food pyramid, lots of servings of grains, kind of an inflammatory type of diet. How did you
hmm
take that U-turn, so to speak, and get into the functional medicine world?
Yeah, I mean, I went through kind of a traditional dietetics educational path, mainly because I was interested in how nutrition fuels our body and makes us function. I started in kind of the sport performance nutrition world and kind of thought that that's what I wanted to do. Nutrition biochemistry is not going anywhere. It's foundation. So I also have a physiology background. But then, you get out in the real world and you learn what it really is.
Yeah.
So I got lucky. I fell into the lab scene early in my career. I took a job with a cardiometabolic laboratory where we, ran and we were hired to educate patients based on lab parameters. And fell in with advanced testing and using labs to motivate behavior change. In fact, I don't know how you do it without labs. There's something to be said for seeing green, red, yellow, and motivating people to change. So spent a long time in cardio. I still love that world. I think it's profoundly important. I love where the direction of gut health is going, with some of the science that's coming out around GLP-1 and metabolic health through the gut. Like I think maybe like the next chapter, but yeah. So the cardiometabolic world is super important. Diabetes isn't going anywhere. Insulin resistance isn't going anywhere. Obesity management's not going anywhere. But I wanted to niche down into the gut. I have a lot of interest in celiac and gluten related disorders that affects my life personally. So I took a turn, went more into the functional lab testing space in gut diagnostics, autoimmune testing.
Hmm.
And so, yeah, I mean, I've been in the lab world most of my career, and I'm happy to have here. And I've been with DSL now for a couple years, and it's a great space, mainly because the GI map is such a good tool, and it's a joy to work with in terms of driving outcomes, looking at the gut, figuring out, I mean, that whole, it all begins in the gut. I believe that to my
Yeah.
core. So it's just fun to work and live it day in and day out, and definitely migrated more into kind of a practitioner education space because that's needed. I mean, we're not learning this in school. I don't think any health profession is really learning this in school unless you're doing the arms that are offered by, IFM and other governing bodies. So there's a massive need for building this education within.
Yeah, that totally makes sense. I mean, the gut is so important. That's where 80% of your immune system is. Obviously, if you're trying to get people to make a healthy diet change, but you don't have good absorption or digestion or assimilation of a lot of the nutrients you're consuming, that's a big factor. And so
Mm-hmm.
I've been using stool testing with my patients for well over 10 years. And obviously, when patients have chronic stress or chronic illness, usually there's some kind of bottleneck on the digestive absorption side, whether it's hydrochloric acid, enzymes, or bile. There may be a impact with microbiome being off a little bit, maybe infections, maybe gluten sensitivity, maybe just inflammation markers. Um, let's just kind of dive in here. So first off, we kind of go to page one of the GI map, right? We talk about a lot of like bacterial foodborne kind of illnesses. How often did these come up? How often do you see them kind of from a lab standpoint? Do they play a role with patient outcome or patients not feeling great? Like the Campylobacter, the food poisoning kind of things?
Yeah, yeah. So, I mean, the page one of the GI map is sort of your rule in, rule out, right? It's similar to a panel that would get run in a setting, in a hospital presenting with acute gastroenteritis. So, how often do you see things positive? Um, I don't know, if I had to put a number on it, 80, 85% of the time you run a GI map, this page rather will be non-remarkable. Everything will be less than DL. But, we
Are you
do
able to see the
often
lab on the
see,
screen? Can you see the lab on the screen?
yeah, I can see it.
Yeah, good. Cool. I'll just kind of
Hmm.
put it up there for your reference for you.
Yeah, yeah. So, but we do see, I mean, there's often typical scenarios where we are seeing expression of C. diff. C. diff's a big one. And then it's really interesting because we see very definitive patterns that unfold with the commensal microbiome balance, right? It's all about balance. And one thing that's true about the GI map are these really, really, really strong patterns that we walk away with these certain cases. So, C. diff, people are symptomatic. We see a lot of asymptomatic C. diff because we're not, this showing right here, expression that we are carrying C. diff genomic material in the gut. So that would be something that would need to be followed with symptom assessment and maybe further testing. But C. diff come up quite a bit. And
Does
there's a
it
lot
matter that it's so high? Is it like, let's say this patient here, right? They're like
of
100x the
medication.
reference range.
Um,
Does that matter?
it does matter that it's so high. Yeah, it absolutely matters. And that's really a critical piece to the GI map. The GI map, we use quantitative PCR, right? Quantitative value of
Hmm.
these organisms high relative to the rest of the ecosystem. So I say this all the time, but the number we use exponential reporting
Hmm.
the left of the E. So, and those are 2 orders of magnitude above this range. It does matter, but again, you'd want to do some sort of symptom assessment, to see if and you also want to look at this page 4, intestinal health, to see what inflammatory markers are doing, if there's any blood in the sample as well. So you got to look at the test as a whole, certainly. But looking at C. diff carrier status, that is something that we see, you know, time to time. I deal with a couple. The other thing that we see on this page a lot is low level giardia,
Hmm.
which is interesting,
Yeah.
because
I've seen that
giardia,
quite
giardia
frequently.
is pretty. Yeah, yeah, we see it. About 10% of samples coming into the lab, have some detected level of giardia. It's pretty ubiquitous in our society. Um, and, it may or may not always present with acute symptoms. But, I wouldn't really want to see giardia rolling around in my gut. So most practitioners feel the same way. So, whether or not we treat every time we find these organisms is a bit of an art as much of it is a science, but you don't know what you're looking for unless you find it. And that's what the GI map is really good at. We tend to see seasonal variations with things like giardia because it is found in water a lot of
Hmm.
times. So,
Yep.
um, we see low levels of E. coli's, but this page is telling us about exposure, right? So usually when we see something pop on page 1, generally there's deficits in the immune function. So we see it with low secretory IgA. Usually there's deficits with hydrochloric acid. So we see that reflective of digestive insufficiency and other patterns on the rest of the tests that can highlight hypochlorhydria because these are our defenses, right? And if your defenses are down and you're exposed to these microorganisms, then your gut is more susceptible, right? So it's just very, very profound patterns that we see time and time again.
That's very cool. And so clinically, when we look at a lot of these things, obviously Giardia, that's a parasite that can have a big impact. Some of these foodborne kind of illnesses that these could be transient, but they could still be a stressor in the gut like C. diff. Now, if we go to page 2 and we look at H. pylori, right, we have some of these virulence factors. Can these be actually cleared out when you knock down the H. pylori? Are they kind of genetically there forever?
They're genetically there forever, but when you functionally work, when you work to lower the organism, genetic expression can change. And then, of course, if you're lowering the organism, the genetic load is going to lower as well. So, yeah, you can see both the virulence factors, and then we also measure antibiotic resistant genes on page 5 for H. pylori, and those can change based on retest. If you choose to do that. But, I believe what you've pulled up here is our sample report.
Yep.
It's would be pretty rare to see an H. pylori profile with this amount of virulence, but certainly the virulence factors can be really helpful at triage and decision making, especially at those
Right.
low levels. Like a lot of times we see, say, a virulence factor can trump, whatever the number may be, typically depending on the virulence factor, because some of them are
Hmm.
sort of scarier than others.
Totally.
A lot of times practitioners will treat, regardless of the level, if there is positive virulence.
Now, I've seen a couple of patients recently where we've treated for H. pylori, like using a lot of the good kind of well-known botanicals, whether it's garlic or mastic or clove or oil of oregano, and we've had a hard time moving the needle on some of that H. pylori. Why is that? Are you seeing a lot of resistance to H. pylori to even the botanicals? And any thoughts on that?
No, I mean, I think with Mastica, Mastica's pretty well established in the literature, and pretty effective. I do think dose is important. And a lot of there's a lot of formulas out there, H. pylori formulas in the professional supplement space. In my opinion, I mean, if you look at the literature of using Mastica against H. pylori, you're typically looking at like 2 to 3 grams per
Yep.
day.
Hmm.
And a lot of those combo supplements don't get that high. And so I think there's a lot of myths there that we're just not coming in with a
So
high
I
amount.
can tell you clinically, I've seen some patients where we're using that level and more, and we're still having a little bit of issues. And then, why does that happen? Is that just a resistance to the bug? Do you typically just recommend rotating in different herbals until we find that right one? What's your take on that?
Yeah, I mean, it's great if you're assessing and reevaluating with testing. We don't always get that. A lot of people will treat based on symptoms, and there can be symptom residual. I mean, you can have symptom improvement without lowering the number. I mean, I find Mastica to be pretty effective.
Yeah.
A lot of times I'll combine it with some agents like DGL licorice, black cumin seed. Those are kind of the big ones. Um, and then there's always kind of a lot of times when you have issues clearing things, there's always the issue
Hmm.
of biofilms. There's always
Yep.
the issue of what else is going on in the environment.
Yep.
There's also this whole question about stomach acid
Hmm.
and whether or not, so kind of the mechanism here for anyone who doesn't know is one of the misunderstood things about H. pylori, or just not understood, is that H. pylori, obviously it's associated with the gastritis. It's an upper GI organism.
Hmm.
If it has a lot of virulence, it can be associated with, the scary things we think about, the peptic ulcer diseases, the gastric cancers, acute gastritis, reflux, GERD. But beyond that, the organism itself produces this enzyme called urease, and urease can
Hmm.
neutralize stomach acid.
Yep.
And
Produces
so a lot of
ammonia. Yep.
times, yep. So a lot of times we're seeing, H. pylori upstream of digestive insufficiencies. So I do think that there's a lot of confusion out there, and, nothing that we do here is black and white. There's just not we get questions every day, like, at what level do you treat H. pylori, and what exactly do you do? And do you use acid? Do you not use acid? I mean, so much of this is just not black and white. But, one of the things that I think people don't understand is a lot of times people with H. pylori need stomach acid. You look at their digestive health markers, you look at the rest of their overgrowth, like they need acid. But and so a lot of people will bring in digestive support with acid right out the gate. That may or may not be effective. Using acid while you're trying to treat H. pylori it's a little controversial. And it can sometimes be harder to treat H. pylori using acid because the organism essentially runs away from acid.
Yeah.
It's,
It's going to
it's
go in deeper into
chemoattractive.
the gut lining, right?
Right, it can. So you can kind of force it to go burrow and hide. So a lot of times we'll wait until, at least 30 days into an H. pylori protocol before adding that in. And that might be a little more effective, if you're running into that problem.
Mhm.
Um, so
Yeah,
something to think about.
it's a different, like, philosophical, like, kind of mindset of what you're doing, right? Because I look at it like this. I very rarely come out of the gate killing. So my goal is to kind of reestablish optimal physiology, optimal gut function. That's
Yep.
digestion, that's enzymes, that's acid.
Yep.
And so many of the patient's symptoms that I see get better when you improve function. It's like you improve the upstream function, the symptoms downstream neutralize, right? So you want to improve function. That's a goal. If we know H. pylori is decreasing hydrochloric acid, it's probably also impacting enzymes because we need acids to activate enzymes, and
Yep.
probably also impacting bile salt. And so then, like, let's say you're a month or two down the road, you're going to start killing. Is it worth, you think, coming in there and pausing the acid, or even adding in a neutralizer like maybe baking soda, or even using Prilosec for a couple of weeks just to make the herbals more effective?
I would never really pull in Prilosec, but yeah,
So if you're trying to not overly acidify, would it just be not adding an acid? Would that be enough? Or would you want to do something that actually
typically
alkalizes?
no, I don't. I personally don't pull in alkalizing agents very frequently,
Mhm.
just because I think people have such profound issues with stomach acid. But just not using supplemental acid while you're trying to treat the H. pylori is pretty much where I land. Um, but yeah, you're absolutely right. I mean, it's not always H. pylori is not always what we need to come out the gate with.
Mhm.
I'm with you. I don't, I tend to be more conservative in killing anything, but yeah, it can always on and deal with later. It depends on the person, their symptoms, what they're experiencing. I mean, if there's a really strong upper GI symptom load, then you're going to want to prioritize H. pylori pretty high.
Mhm. Absolutely. And then you like to add in a lot of nutrients on the kind of soothing side, whether it's DGL or glutamine or okra or aloe
Yep.
out of the gates as
Yep.
well.
Aloe's great. Yep.
Yep.
Aloe's great. And then there's a lot of things you can do with diet to kind of prevent adherence
Mhm.
of H. pylori. A lot of these virulence factors actually work by promoting adherence. So there's quite a bit you can do to dispromote's not really a word, but like to prevent
Yeah. Yeah.
adherence. So things like cranberry
Yep.
can be really helpful. Green tea, Manuka honey can be really helpful. And then you want to avoid things
Yep.
like super high
Ginger,
sodium,
right?
super high nickel, Yeah, well, ginger could be helpful from a motility standpoint, but high nickel is one of them. Like, people eat a lot of almonds and that can be a really high nickel load. So there's a lot you can do perspective, even just to, balance H. pylori. And it's not always about killing the organism to eradication. I mean, maybe in this scenario, like looking at what's on the screen, a really nasty virulent bug you probably want gone. But sometimes if we're dealing with low levels and just some like mild hypochlorhydria, it's really about keeping the organism in check.
Yeah. And I'll use some biofilm busters as well. Ginger's one of my favorite. I mean, silver's up there. NAC is great. Serapeptidase. What are some of the ones that you like?
Um, N-acetylcysteine is a
Yeah.
good one.
NAC. Yeah.
Cinnamon can be really helpful, particularly there's an organism on page 3 called Pseudomonas, which is a strong biofilm
Yeah.
former, and I'll usually pull in cinnamon when we have that on board as well. So those are probably my top favorites.
Foods. I know you mentioned like cranberry, avoiding the nickel. I've seen things like broccoli sprouts and blueberries being pretty helpful as well. I mean, obviously, you have things like you mentioned manuka,
Hmm.
garlic. I've heard green tea is really good. Some of the probiotic rich
Green
like
tea.
sauerkrauts, as long as you're not getting bloated. Any other thoughts on those?
Yep. Flax can be very helpful as
Hmm.
well. Yeah, green tea, cranberry, flax. Um, and honey. Those are my big ones.
Great. How often do you see partners spreading things back and forth? How important is addressing the partner or the spouse so things aren't being spread back and forth via saliva and such?
I think it's an important consideration. I really do, especially if
Hmm.
you're backing yourself into a corner, the scenarios if you're not being successful with your treatment. I mean, it is a heavily transmissible organism through saliva.
Yeah.
I mean, I have a 4-year-old, and I mean, come on, like I eat
Oh
after her
yeah.
all the time, and so it happens. I don't subscribe to not testing and treating asymptomatic individuals just because you're treating their spouse. I would
Hmm.
want to get that test. But I mean, I work for a lab, I like data. So, that's sort of my philosophy. But yeah, I do think it's an important consideration and evaluation, especially if you're going to exhaustive efforts to, help out a person. You want to look at, how they're spending their days and who they're spending their days with.
Yeah, that makes sense. I think it's important. Do you see pets as a potential vector as well for H. pylori?
Not so much. I mean, unless your dog is particularly licky and slobbery and
Yeah.
in your face a lot. No, that's not something I've even really given a whole lot of thought, to be honest. But I don't know. It's not something I typically
I know
focus
with
on.
cats, I know Giardia is pretty common in cats. That's so I do.
Yeah, and
Cats
dogs.
can be a
Giardia is
micro.
common in dogs too.
Yeah,
Yeah, no,
yeah.
they can be a vector in that regard for parasites, particularly. Not so
Mhm.
much so with H. pylori.
Interesting. Well, let's talk a little bit about the commensal bacteria section. I get this coming up a lot with patients. I'll see patients with have a lot of dysbiotic bacteria. These things will be the commensal stuff will be out of balance as well. I always kind of prioritize the dysbiotic stuff first because if you clean out the bad stuff, then when it comes to the repopulation phase, a lot of times with good fibers and good digestion and good probiotics, that may take care of itself. How do you kind of break this section down when you explain this to patients or people calling you up? How do you break it down? Because I mean, kind of my take out of the gate is we have our beneficial bacteria, our lactobacillus and bifido, and then we have our big family of bacteria, which is important for fiber and plant-based products to have
Mhm.
good levels if we're too low on that. And then of course we have the Akkermansia, which is really important for mucus production. And when I see a lot of imbalances on the higher side, and I have a lot of dysbiosis, I always tell patients, wait, we're going to clear that out when we get to the big bugs, and then we'll work on repopulating with pre and probiotics on the backside. How do you address that? What's your philosophy around that?
Yeah, so it depends on the pattern. And I will say that this section of the GI map is sometimes the hardest to interpret.
Hmm.
Sometimes it's obvious. Sometimes, and we added these color bars and these tick marks about a
Which is
year
very
ago.
helpful,
And
by the way.
yeah, I
Very
agree.
helpful.
I totally agree. I was part of that design plan team because, yeah, it was pretty hard to read. We had practitioners completely missing low levels like Faecalibacterium pratenitzi, like the reference range is 1E3. We would have people come in with, 2.5 E3, and the test didn't do anything to indicate that. I mean,
Right.
look at the broad range of normal. So these color bars and tick marks are vastly helpful. And I will say sometimes you
Totally.
see there's an obvious skew to the left or the right. A lot of times,
Yep.
sometimes we will see obvious insufficiency dysbiosis where everything's trending low. And sometimes we see obvious overgrowth when everything's trending high. And yeah, those are a little bit easier, a little bit more obvious. If things are low, um, obviously depending on the rest of the report, but that's more of an insufficiency picture. That's more of we really need to come in here and rebuild and support and repopulate with all the good things that we know how to do, before we do anything else. Really, I mean, your gut's depleted. We need to build that up. If it's trending on the high side, I mean, that usually indicates, it usually is downstream of digestive insufficiency where we have a lot of overgrowth. We have a scenario where there's just tons of microbes and tons of fermentation happening
Hmm.
in the lower gut, and those symptoms of bloating and distension. I mean, how many of your patients
Yeah,
have those symptoms? And we see that over and over
absolutely.
again. um, in terms of how do I go through this, so I always take a look at the phyla first. So down
Hmm.
at the bottom of that page, bacteria phyla, we're looking at
How would you
bacteria, yeast,
describe
and
phyla? Is
firmicutes.
phyla like the big overarching family, and these things are kind of subfamily members within that?
Yeah, yeah. So go back to, high school biology, kingdom, phylum, class,
Yep.
order, family, genus, species. So phylum is one below kingdom. We're talking about kingdom bacteria here. So phyla is a very, very broad net. Bacteroidetes and Firmicutes together make up about 90% of healthy human microbiota populations in our gut, right? So if in the case of insufficiency, if everything's low, phyla are at the E10 level, then you organisms down there versus if both of your phyla are like in the E13, well, shoot, there's there's tons of stuff going on there. And that's a scenario where I would don't even ask me about a probiotic right now. We don't need it. We don't need to add
Oh
fuel to the
yeah,
fire. We need
definitely SIBO
to
for sure.
work on your digestion.
Mhm.
Well, SIBO or lower bowel. I mean, it's not just SIBO. It's, bacteroidetes are more colonic, for growth, not necessarily small bowel, but you can get it again, look at the page
Yeah,
specifically. This page can be tricky. And so we start with the phyla, and then we look above the bold line. And of course, this is a sliver. We are looking at very well established keystone populations here. We're not looking at this is not a sequencing test. We're not taking a broad stroke at everything that's in your gut, but you can get a lot of insight from Escherichia. Escherichia, I feel like when it comes to the mucus layer, Akkermansia gets all the cred, and it is very important, don't get me wrong, but Escherichia and Akkermansia kind of work together. So if you have both of those organisms trending low, your mucus is just not in good shape, and you can determine that, and then you can design your protocols around that. Akkermansia, like I was saying, with my metabolic background, the research that's coming out with this metabolic interplay and its regulation of GLP, I mean, that's really exciting. And we have more tools in our toolkit now for bringing that organism up. And then Faecalibacterium pratenitzi and Roseburia primary butyrate producers. And Faecalibacterium pratenitzi is one that I look at. I look at that organism very keenly. And in these inflammatory situations, things like, diff, there's IBD. We see Faecalibacterium less than detectable all the time. And that relates to butyrate production through the gut, quelling inflammation, establishing immune function, establishing that gut barrier. So those are some of my favorite to talk about and hone in on low, right?
So when you see some of these things on
Sometimes,
the higher side, bloating, gas, those would be the big symptoms. It'd be a big sign that low stomach acid, low enzymes are present as well because you're not breaking some of these things down. What does that mean to you, big picture, when they're high?
yeah, so we want to look at those digestive markers on page 4. So it's really nice.
Hmm.
And I refer to those. I look at those yeah, I mean, we're just not having diet. Hypochlorhydria and digestive insufficiency are huge risk for digestive tract. And maldigested protein, when we get into page 3 and talk about a lot of the more inflammatory organisms, preferentially protein. And maldigestion got overgrowth of organisms that produce. Well, now you're looking at things like ammonia as byproducts. And those are just, it becomes this weak digestion,
Hmm.
inflammation, toxicity, cellular toxicity as well.
Hmm. Absolutely. Now, when you see low Akkermansia, do you like to add in Akkermansia typically, kind of as in the prebiotic phase, maybe after you do gut
It,
killing?
yeah, it kind of depends what's going on. So are you referring to the new Akkermansia product that's
Hmm.
available?
Yes. Yep. Yep. That's correct. The one that's been out for a year
Yeah,
by, I think it's
yeah,
by Pendulum.
yeah, yeah. So I like that company. There's some real research coming out of there. Um, you know, I I don't know. It's, a lot of times we're really prioritizing for patients. So, having an extra one organism supplement, it's not always in my protocol. Let me say that. But I am certainly considering it. I'm certainly considering it when there's metabolic dysfunction. But you can also do a lot with Akkermansia with red polyphenols in the diet, polyphenol based supplements, red powders that you can add to foods or smoothies, things like that. Intermittent fasting is also a really good way that organism grows up in the fasted state. So I'm not big on extremes in fasting, but just um, things like the overnight fast help. Akkermansia helps regulate serotonin through the gut. So a lot of motility nerves stimulation. Akkermansia, it's all for that same goal of enhancing motility as well. So yeah, I mean, but we have seen that pendulum product effectively raise Akkermansia on GI map. I mean, as you would hope it would. It's just a matter of how lasting that is. Now are we like, do we need to take this forever? Will that come down if we stop
Hmm.
supplementing? Like, those are the things we don't really know yet.
Hmm. And the goal really is to build up that mucus layer, right? To help with the gut permeability, to help with digestion. Because when we have that really inflammation, a lot of gut inflammation there, that gut's going to be a little bit more raw. So building up that mucus layer is kind of the goal with that Akkermansia, correct?
Right. Yep. Yep.
Okay, cool. All right, so that's helpful. Anything else you want to add here, kind of clinically, of what we'd want to think about or focus on here?
I kind of lost you for a second. Anything I want to add related to this?
Yeah, anything else you wanted to add clinically, kind of related to this section of the test here, before we go on to the dysbiosis section?
Yeah, well, I mean, again, it's all about patterns. It's all about looking at this next to the rest of the test. The one line item that other than digestion is looking at this section next to secretory IgA. You tend to pattern. Um, Inclined low secretory IgA, they go hand in hand.
Hmm.
So
Hmm.
that's a good clinical protocol that a lot of practitioners do there.
Excellent. Let's go to this section here. What are the big take-home values clinically that you see when you're reviewing with practitioners?
Yeah, so into two parts, right? You've got your opportunistic bacteria and methanogens, and then you have your fungi yeast, which are obviously also opportunistic. Page 3 is a big feature of GI map. This report isn't the best representation of some of the overgrowth that we find, but these organisms on this page are fairly carefully selected due to clinical relevance. And if you notice on the reference range, some of these are really microbes, not present in very high quantities. So it takes a very sensitive technology platform to identify them in stool, things like our Klebsiella, our Morganella, Pseudomonas. So we get really, really granular information on this page, depending on which organisms are overgrown, what the symptoms are. I have some favorites. I think I find Pseudomonas to be really fascinating. They're LPS carriers. They actually can they have stays partially gluten and the immune system. These organisms can, when they accumulate, when they grow up, they do tend to grow up more in the small bowel. And so they can knock down the capacity of your brush border enzymes. They can get in the way of, well, like DAO is on the brush border. Pseudomonas also produces histamine. So you can
Hmm.
get like histamine from this page, looking at the organisms that produce histamine. I mean, we can kind of go on and on. Staphylococcus aureus is a
Yeah.
really interesting organism, very pH sensitive, has a lot of correlations with skin. So we have so many patients with, your eczemas, your
Hmm.
psoriasis. My last consult today was a
Mm.
3-year-old patient who had an E4 level aureus, and really aggressive eczema, since 6 months of age. So, connections like that are really profound. Autoimmune. So Klebsiella is one that gets a lot of it. It's a histamine producer, has autoimmune associations. A lot of organisms aren't. So if we, am I breaking up a lot?
Hmm. No, you're good here. But it's interesting you're talking about some of these
So
bacteria producing histamine, right? Because, oh, can you hear me okay?
yeah,
Yeah. All right. So I was just talking about histamine here because you were kind of bringing it up. Histamine, people get very focused on avoiding histamine foods, using DAO, avoiding histamine in the environment. But a lot of times, which that may be helpful, but a lot of times that histamine sensitivity could be really present in the gut as a root cause
yeah, yeah.
through a lot of these bacteria imbalances, right?
Overproduction. Yeah, overproduction in the gut of histamine producers is definitely a pattern that we look for.
Yeah, absolutely. All right, so you can keep on going. We were just talking about staph and strep. Go ahead with that.
Yeah, so I was just kind of rattling off some of my favorites that we have discussion points about. I mean, obviously with all of these, it's important to kind of just keep the symptomology in mind, the clinical presentation. Um, um, I don't know. I'm getting a lot of comments that people can't hear me. What do you want me to do? All
Yeah, there's definitely a lag here. We're just going to keep pushing through, though.
right, I might. Do you mind if I take this headset off because I've been using
Yeah,
it all day? It might be
yeah,
dying.
yeah. No problem. No problem. I'll let you do that, and I'll keep on riffing here.
All right,
So,
all right. I don't know if
yeah,
it's
so I'll keep
better
on
or
riffing. No problem.
I've been on
No problem. I'll let you
the phone all
change
day.
the headset here. Take a minute, and I'll kind of do a little review here on my hand too. Are you able to keep going here?
Yeah, I can
Okay, go
keep
ahead.
going.
Yeah, go ahead.
So anyway, these microbes, it would take all day to sit here and go through each one line by line. We do have information on microbes in guides. You get the hang of this, the more tests that you use, the more times you see them. And again, the thing to keep in mind here is these are opportunists. They grow opportunistically. So you have to keep coming back to what is presenting this opportunity. And, it may be low, weak commensals. It may be digestive insufficiencies, hypochlorhydria. It may be recent antibiotic use. It might be a combination of all three.
Yeah, absolutely. That makes sense. That makes a lot of sense. Now, what about fungus and yeast? I see this here a lot. I'll run a lot of times organic acid testing side by side these tests, and I'll come up with diarabinose or diarabinitol. A lot of times when yeast doesn't even come back on here. So I always tell patients when yeast comes back a little bit, it tends to be significant. Can you give me your take on the kind of the yeast overgrowth section?
Yeah. So we are looking, this test is measuring microbial genomics in stool and looking at specific targets of this yeast collection. Candida being the big one, Candida being the one that gets most of the attention. So I think a lot of times people are surprised that we don't more frequently on the GI map, although I see plenty. There's criticism out there that the GI does not pick up not they're invalid criticisms because we see it all the time. I think I had like 5 consults on Candida today. But when I do see it, it's usually pretty significant in my opinion, and it does relate to canon, specifically in the gut. Now, can you have systemic issues having it colonize
Outside
the
of the
gut?
gut, for sure.
Yes, you can.
Hmm. Hmm.
Yeah,
Yep.
people will pull in organic acid test, antibody, Candida antibody testing. I used to work for a lab that did Candida antibody testing, and you would find candy like yeast blood antibodies can linger
Yes.
for much longer than looking, genomics in stool.
Hmm.
So, but I will say when I see Candida, a sense of digestive insufficient as kind of a co-infection with H. pylori quite often. And I see people are really symptomatic when you have candida overgrowth in your gut. And I see a lot of psychosomatic symptoms, a lot of anxiety, brain
Hmm.
fog type symptoms with and I will say too that the organic acid testing, um, you know, I don't know what I want to say here. Like those tests will find it. They'll find yeast probably
Yep.
more often than a stool test like this, but it's not always specific for those microorganisms. So
Hmm.
here it's like you're finding exactly what you're looking for.
Yeah, absolutely. Yeah, I'll see yeast. I'll see it if I see it at all. Forget it's even flagged, right? If I see it a little bit, I'm concerned. That's kind of how I look at it. I'll
Yeah,
also run
me
that
too.
diarabinose,
Me too.
and I'll see a lot of times.
There.
Go ahead. Hmm. Yep. Yeah, and I'll run the arabinose as well, just because, like you mentioned, yeast may not be fully in the gut. It could be outside the body, and you may need another kind of a systemic kind of net to catch that. So it's good to look at it. I've yet to see a viral issue come back here. Have you ever seen a viral issue in the gut?
Rarely.
Yeah, pretty rare.
We just don't see the viral colonization. you're looking for viral load, you need to be.
Yeah. I also very rarely see worms too. Let's go to page 4. How often do you see worms coming back?
Correct. Yeah. I mean, you really shouldn't be finding worms in third world countries. They're not super common. But we do see the protozoa fairly frequently, at least at low levels.
Exactly. And on the parasite side, I'll see blasto a little bit. I'll see D. fragilis a lot, endolimex. Which ones do you see the most frequent based on your experience? And then what kind of symptoms do you typically kind of correlate? The same kind of digestive stuff, or do you notice sometimes it's not even digestive? Maybe it's mood, it's fatigue, it's brain fog. What do you notice?
Yeah, so I will say that 9 out of 10 times you see one of these low level parasites, or even if they're lab high, again, the kind of low immune function and patterns that point to hypochlorhydria. They are also opportunists. They won't be there unless you've been exposed to them and your body's. So that kind of sets the stage. We see the blasto, we see Dientamoeba fragilis. I do see Endolimex nana and Entamoeba coli pretty frequently. Sometimes we see and I don't always Endolimex nana, Entamoeba coli. You don't always need to really take action directly there. A lot of direct these foundations, they'll go away on its own. Blasto and Dientamoeba fragilis tend to be more tenacious. Blasto is a really common co-infection with H. pylori.
Yep. I see that a
So,
lot.
yep, yep. And the skin, again, going back to the skin with blastocystis as well. It depends on the level. There's a difference. I feel like with these, there's a difference between it being lab high and just detected in terms of symptomology. And a lot of times when we see these low levels, it's really just, kind of secondary to weak digestion and weak immune function.
Totally. So if we kind of hammer on some of the skin stuff, because I see that a lot, and I always tell patients that the skin is the mirror of the gut. What are the big microbes that you connect to the skin? So you mentioned blasto. I think you mentioned staph. What else?
Yeah. So, well, H. pylori because of its effect on stomach acid.
Yep.
Blasto's a big one.
How does stomach acid impact the skin though? Is it just food not being broken down, fermentation in the gut, and kind of the skin being used as a detoxification mechanism?
Yeah, and it low stomach acid doesn't operate other microbes, right? So it's
Hmm.
this vicious
Hmm.
cycle. Like
Hmm.
you've got to have decent stomach acid, or everything else is for naught. Honestly, it's extremely
Hmm.
important. So that's a big one. Blastocystis hominis, Staph aureus, like I mentioned before. Candida. I mean, Candida is a big one with skin implications as well.
Yep.
So those are probably the main ones on my radar. Oh, and then the histamine. I mean, the histamine patterns. So we have, I don't know, 7 histamine producing bacteria.
Yeah.
Um, and if I don't know, 4 out of the 7 or 5 are detected or elevated, comfortable saying this is histamine growth. And, that can obviously have a lot of skin manifestation as well.
Yeah. And so what are the big histamine ones? You mentioned Pseudomonas. I think you mentioned Klebsiella as well. What are the big ones besides those two?
Morganella is a really big
Yeah.
one. Pseudomonas is a big one. Um, Staph aureus is interesting. It doesn't actually directly produce histamine, but it activates mast cells. So it's a similar mechanism, I guess you could say, but it's more of a mast cell activator than a histamine producer. Klebsiella is a big one. Proteus is a big one. Citrobacter fruindi specifically is a big one as well.
Hmm.
Hmm.
Hmm. And just curious, like, do you notice the correlation with the orders of magnitude above the reference range? If you're 1x, 10x, 100x, 1000x, you notice an intensification in symptoms the more the genetic load is?
Yeah, I mean, yes, yes.
Hmm.
Some of it, I mean, sometimes you see like, I mean, I've seen Pseudomonas at like E9
Hmm.
before.
Yep.
Um,
I've seen it very
uh,
high like that.
Proteus is not one you see every day, but I've seen very high levels of Proteus that, I feel like have almost been, in patients that present like IBD, but but their inflammatory markers look good. And I'm like, well, maybe this is just a Proteus overgrowth. But yes, I mean, absolutely. And that's the value of, again, the quantitative reporting is so that you can get that degree of magnification. Like, I'll be honest, we see Staphylococcus aureus a lot. Like, we see it
Yep.
all the time, but there's a big
Hmm.
difference between a detected E2 level of staph and like that eczema patient I saw today that was like high E4. I mean, that's a
Right.
huge difference.
Right, exactly. And then what does it mean when you're going through a protocol? You're supporting digestion, you're supporting enzymes, obviously healthy diet, you're using therapeutic level of herbs, and then the levels go up between tests. What does that mean to you?
Well, that depends. And,
Hmm.
one thing that I think needs to be understood is when to retest. I think, so we typically recommend retesting 4 to 6 weeks after a protocol has finished. Practitioners will
Hmm.
retest too early. I had a consult yesterday with someone who, the provider was not the primary provider. He was just trying to help. He was kind of a more auxiliary provider, and the patient
Yep.
had vancomycin for C. diff. And so, long story short, she was on vancomycin when she did the test, and the test looked horrible. But I
Mm.
was like, well, there's an effect of being on an antibiotic. We're looking at kind of what is spilling out here. So really what you need to do is treat, wait, give that microbiome time to stabilize, rebalance, make sure what you were trying to kill, time to grow back if it's going to, and then retest. I'd say more,
So, mhm, go ahead.
yeah, when I see this scenario where things get worse, a lot of times there's retesting too early. So that does happen. But it's also possible that, working with the gut is like peeling back layers of the onion. I mean, sometimes you treat one thing and you else, candida and H. pylori. Um, so I don't know if that was helpful, but that's how I would answer that.
Yeah. And so when you say swapping, is that kind of as you're going deeper into the gut lining, you may have kind of borrowed microbes that are kind of working their way out?
Right. Or sometimes they're masked on the first test and then they're uncovered on the second.
Interesting. And then just curious too, you're kind of we talked about, let's see here, you hit the, oh yeah, talked about like a length of time after the test from being off antimicrobials. Is that 4 weeks? Is that about a month or so? And then does that also include probiotics? I mean, I think you'd want to be on probiotics to prevent a rebound overgrowth. Would it be about a month or so after stopping herbs?
Yeah, so 4 to 6 weeks after treatment, right?
Okay.
As far as supportive supplements, um, you can be when you test. I mean, you can be on probiotics when you test, just
Hmm.
when you're interpreting the results. I mean, if you're on a lactobifido
Yep.
probiotic, chances are your lactobifido are gonna look better on the GI map.
Yep.
So just
Or
kind
even
of
a little too high, maybe.
yeah, yeah. So just kind of keeping that in mind in your interpretation.
That makes sense. Very good. All right, so we hit some of the parasite stuff here. Why don't we go down to some of the intestinal health markers? So just kind of my take here out of the gate, biggest thing that I like to focus on is elastase and steatocrit, because if we don't have good enzyme or acid, or when I see low elastase, a lot of times there's an acid connection because acid's a big trigger for elastase, and also acid's a big trigger for bile production and lipase from the pancreas. So these I think are really important. Why don't you give me your take?
Yeah, no, I think you nailed that, honestly. I couldn't have said it better myself. So yeah, steatocrit is a reflection of fat in the stool. Elastase is a reflection of pancreatic output. We don't have a direct assessment for hypochlorhydria on this test, but often if there is low acid, you will have reduced pancreatic output, and that's going to affect your fat, your protein, and your carbohydrate digestion. So yeah, I mean, I think you're spot on there. With steatocrit,
Does taking enzymes, would that influence the elastase or would that not? Would it just be exogenous enzymes, therefore it wouldn't bump up your internal production?
correct. Like, we don't supplement with pancreatic elastase 1. So, taking
Right.
enzymes should not, if you're taking supplemental enzymes, they really should not pick up on a lab. You're looking at the ability of how robust the pancreatic function is. So taking enzymes theoretically should not influence the result.
Got it. But over
We
time,
do
just by
see
getting
that.
your gut health better and getting your acid levels up, that would
Right.
probably over time influence pancreatic function to improve.
Exactly. Exactly. Yeah. And, just a pearl on steatocrit.
Hmm.
There is some element of dietary fat intake in steatocrit. So the research shows that Western diets, which are typically higher in fat, have higher levels of steatocrit. So if there's kind of if steatocrit seems anomalously high, you know do a diet intake. How much fat is this person actually eating? Are they keto? Are they taking oodles and
Hmm.
oodles of omega-3 supplements? Things like that, if something's not quite right. And the other thing, whenever there's a steatocrit elevated, I like to look at, obviously, like a serum vitamin D is a good place to start, because there could be
Hmm.
malabsorption of fat solubles as well. So
That makes sense. Plus, is there a lot of blonde or clay color stools? Is the stool floating? Is there excessive streaks or skid marks on the toilet seat? Those would
yeah.
probably be all good indication as
Yeah,
well.
absolutely.
Good. Now we talk about gluten antibodies, right? So is this, if you come back with high levels of gliadin, how I look at it is that's indicative of gluten sensitivity, but may not be necessarily celiac. Can you expand more on the gluten marker and then celiac versus allergy or sensitivity?
Yeah, absolutely. This is my jam. So this is a secretory IgA antibody response to gliadin protein.
Hmm.
Gliadin is the more immunogenic protein found in gluten. So this is a fecal secretory IgA antibody response. We cannot use this as an assessment for celiac, period, end of sentence. So that is to test for celiac. You're looking at a blood test, looking at tissue transglutaminase 2 antibodies, at least, usually with a total serum IgA. So I think it's imperative. Like, I think everyone should be tested for celiac every 5 years. But unfortunately, this test is valuable, but we can't use it as an assessment for celiac. So what is mucosal immune, more of an acute disease? It's the mucosal. It tends to indicate an mucosal response and increased. The gut does not like this protein, so antibodies against it.
Makes sense. And so, what are the conventional lab markers that you're going to use to look at celiac sensitivity outside of, like, your type of scope that's going to give you a Marsh score, which is going to look at the microvilli atrophy? What markers would be more clinical for the celiac markers?
Yeah, really good question. I mean, I think we're moving towards the gold standard being more the antibody
Hmm.
and deaminated gliadin peptide antibody. So if you get a celiac panel through Quest or LabCorp, that's typically what they're teaching. A lot of practitioners will use, like, what's called the 4 out of 5, in that that test, clinical response to a gluten-free diet, genetics. So you can certainly run genetics, HLA-DQ genetics, celiac.
Yep.
They do, but literature states that you need to have celiac. Um, there's a lot of ways you can go around that. And even this gluten antibody test on our test it is exposure based. So if somebody has been gluten free a long period of time, really no antibody test is going to be completely valid. I mean, the biopsy as well. You have to have that exposure to
Exactly.
the disease state. So it gets tricky for people. That being said, being 100% gluten free is challenging, very challenging. I've counseled umpteen amounts of patients through it, and even in the most educated person, there's still really unfair levels of cross contamination, hidden sources. I don't know if any of you follow, like, Gluten Free Watchdog, but there are groups of people out there that test foods with their NEMA devices and you find it in spices, you find it in things like uh, Philadelphia cream. Things that should not have gluten in them unfortunately do. And so this is a pain point for a lot of people, but it's nice to have these that it can tell you when you're being exposed, even though you don't think you are. I saw that a couple times today, actually.
Very interesting. And last but not least, we have these inflammation markers. Calprotectin's kind of been a gold standard for you guys for a while. You guys added this EPX marker last fall. Can you kind of talk about the two and kind of the how they differ?
Yeah, so calprotectin's been around a long time. It is it is well established. It is not a diagnostic marker of it on its own, but it is part of the diagnostic workup traditionally in IBD. It has a lot of implications in IBD, and it can really use to differentiate IBS from IBD in clinical workup. So that's been around a long time. Calprotectin, this is something a lot of people don't know, is specifically reflective of neutrophil infiltration to the colon. So it is looking at colonic inflammation specifically. Like, oh, there's tons of inflammatory dysbiosis. Why is calprotectin in a normal range? And it's more like, well, you've got a lot of inflammation, but it's higher up in the bowel. So
Got
calprotectin,
it. So calprotectin's more colon, and then you can have other inflammation in the small intestine that may not represent itself on the calprotectin.
correct, yeah.
Okay.
Eosinophilitis is also around a while. It's not a protein, you know. I will say it's nice to have inflammatory marker because
Yeah.
of what I just calprotectin being so specific to the colon. So eosinophil activation protein can be helpful. It's very non-specific though. So there's a lot of reasons why it may be elevated. So it's a lot of times it's more of a consequence than a cause. But it can elevate in IBS. It can elevate in food sensitivities and allergies. It can certainly elevate in IBD. And this is one where I like to use, obviously we use numbers, to me, there's a big difference between an EAP at 2.5 and an EAP at 9, and so, at those lower levels of inflammation, it tends to reflect more kind of like food antigen inflammation, sensitivities, allergies. Barrier permeability on its own can rev up the EAP. At really high levels, then you're getting more into that chronic disease. A lot of times you'll see high EAP with high calprotectin in like an IBD scenario.
Excellent. Very good. And you said the EPX protein is a little bit, it can differentiate between IBD and IBS, you said?
Protectin?
The EPX
That's a
protein, you
strong
said,
mutation.
could kind of differentiate? Hmm.
Correct.
Okay, got it. Very good. Anything else you want to highlight about the IgA or any other markers here that you want to kind of emphasize?
I don't know. We've covered a lot. I mean, zonulin is always exciting. Zonulin's an add-on on the GI map, so you don't always get that on the reports, but
Hmm.
I do find it useful. It relates a lot to inflammatory dysbiosis. I'm sorry, insufficiency dysbiosis. So you're going to see zonulated more so when the commensals are weak, particularly those butyrate producers. Um, I always like hate on the connection between gluten or gliadin and zonulin. There is a really strong connection there. We know that gliadin can bind to zonulin, is released. So, kind of gluten driving leaky gut thing, there is some reality to that. So zonulin's a good thing to have. People resonate with it. It's elevated. It's another one of those strong motivator for compliance when we see it elevated.
Very good. Awesome. All right, very good,
Yeah.
Kat. Well, I think you dropped some good knowledge bombs here. This is great. We'll put it out here for all the listeners. We'll put some links down below to access the test or access some additional information or references on the topic. Anything else you want to leave us with here, Kat?
No, I mean, sorry if we had connectivity issues. Back for a part or something later. But yeah, I
Hmm.
mean, thanks for the test. Thanks for
Absolutely. Yeah, we'll try to clean it up as much as we can in post production. Awesome. Well, thanks for being here. Nice chatting with you.